Welcome everyone. This is an ongoing series of surgical webinars put on by SAGES. I'm really excited that everyone can show up, though people are probably getting a little bit sick of telemeetings lately. Before we start, I'd like to say a little bit about SAGES. SAGES is an organization that's really near and dear to my heart. It was the first surgical organization that I joined, and I joined when I was a resident like you. At that time, SAGES was at the forefront of minimally invasive surgery and has remained to be a leader in that field. One of the things that really excites me about SAGES is the people. I've gotten to know so many great people through SAGES and been educated by so many great people in SAGES. And in that effort, I reached out to some of my SAGES friends this afternoon to go ahead and help me with this webinar. So we got everyone together and came up with a really great show for you today. We're going to start this afternoon with Dr. Jocelyn Chevry. Jocelyn is a minimally invasive surgeon at the University of California, San Diego. She completed her minimally invasive surgical fellowship and then joined faculty at UCSD, where she is an assistant professor. Jocelyn is a very busy minimally invasive hernia surgeon as well as foregut surgeon. She also at Intuitive Last Track was one of the busiest surgeons in all of the West Coast in inguinal hernia repair. So I think that she would be an outstanding person to give a talk on robotic inguinal hernia repair, and is gracious enough to do so. So Jocelyn, thank you.
So thank you for that introduction, and I'm very privileged to be invited to this webinar to help enhance everyone's knowledge and obviously time spent during this COVID crisis. Obviously, I'm going to be the warmer-upper, which is reasonable given the fact that some of the hernia gurus you're going to be listening to have taught me everything that I know about inguinal hernias. So here's robotic inguinal hernias the way I see it. This is a very robust topic, and my goals are to consolidate a little bit of the anatomy, take a little peek at the data on key points on this huge topic that could be a week-long webinar. My experience with robotics, as Dr. Jacobson alluded to, it's newer that I got shopping in the robotic field, and certainly I like using fancy toys, so I'll tell you about that, and then some future directions as I see them. It's hard to not go back to anatomy. We talk about inguinal hernias. Henri Fruchot is a French anatomist and surgeon who obviously was one of the first people, I think, to allude to the fact that we are inherently weakened at a certain point in the inguinal canal, this myopectineal orifice, which certainly has come up more of recent dates. The anatomy, for me, I remember being a resident, and I probably looked as fearful as this poor guy getting his hernia fixed. I remember trying to recite all the steps of an anterior approach, hoping that I'm going to get to do it if I know all the steps and such and such. And it used to make me feel quite, challenged anatomically, even more so than other areas in the body. And then I started to think of names, Strohmeyer, Perman, Bassini, Scholdice, McVeigh, Lichtenstein, Stopa. I mean, if all these amazing surgeon anatomists had to come up with different ways to attack this problem from an anterior approach, maybe it's something that challenges most. And if we look at anatomy in hindsight, I think that might be the case. When we look from the inside, it all became a lot more apparent to me, and I think it's still a learning curve that a lot of people trying to go from open to a minimally invasive approach struggle with. But the anatomy makes sense. The interactions between structures and key structures make sense. We start to appreciate those tissue planes that we never really appreciated before. And I think that that really helped evolve my understanding of the inguinal canal. And then as we start to revive the old 1950s critical view, we're bringing it back and going retro with this critical view of the myopectineal orifice, which I'll talk about later, but really giving us an idea that anatomy is so important to be able to do our job in inguinal hernia repair correctly. This is a common problem. This is something that's not going to be going away. The amount of inguinal hernias we're doing is only going to continue to go up, I think, as longevity goes higher and higher. So I think that this view is important, but because we're trying to use is landmark structures in the inguinal canal to allow us to identify areas of weakness or problems, also identify areas where we can get into trouble, not to avoid them, but actually to expose them. And the exposure is important because our whole goal is to be able to patch this with a full coverage of this myopectineal orifice, something that we didn't quite appreciate in the earlier days of hernia repair. Now, moving on to what we're actually dealing with, I think that most would agree that physical examination is the hallmark of detection for an inguinal hernia. I think it's important as we just kind of work together as teamwork and not trying to overutilize tools that don't need to be used, because going forth with imaging is often inappropriate. Once you find a hernia, you could probably stop there and let your surgeon carry on. That being said, I think that there is a role for imaging in the diagnosis of occult hernias. And oftentimes we have patients who have different symptoms, different physical exams, sometimes one showing one thing, the other not supporting it. Therein is a role for imaging. And there was a nice paper put together trying to highlight an algorithm that could guide us. But I think for me, it lets me know that if I don't find anything on my physical exam, there's nothing wrong with getting some imaging. Obviously, a surgical exploration is always possible, but that's a big step as far as, risk and resources. Also, the role of an MRI with occult studies, we're starting to realize may have a valuable role. So imaging is really to support your clinical findings. Now, to go back on what we're doing, can we do nothing with inguinal hernias? Yes, we can. And I think that we all know that there are some good trials with big studies showing us that watchful waiting is safe for patients. Even when you focus on pain scores, it is safe for patients. A lot of these patients may move on to have surgery, but it's going to be at not putting them at more risk for emergent repairs based more on their quality of life and their pain scale. So it's good to follow these patients, but to know in a transparent conversation with your patients that doing nothing can be appropriate. Watchful waiting is an appropriate management. But if you're going to patch holes or sew holes, how are you going to tackle that in this day and age? There are just so many options. I think we know that mesh is okay. And I came from Toronto where Shouldice Clinic, we used to joke, is where good surgeons go to die because there's always going to be hernias to be fixed. And a Shouldice repair, when done repetitively, can almost be therapeutic. I'm not sure who for. I haven't done a Shouldice repair in quite some time. But in this day and age, that's not really what we need to be pushing for. Mesh is safe to use. It decreases recurrence rate for hernia repair. It does increase the rate of having seroma formation, but that's something that we can deal with, and we're going to talk about that briefly. But then what about pain? Chronic pain after inguinal hernia repair through the literature. I think we're doing our best by appreciating a minimally invasive approach. But I think we're also very lucky to have colleagues who have really taken on chronic pain to explore it in a lot of detail well outside of the scope of this presentation. But I think we can say with chronic pain, and we continue to allude to it pushing forward with mesh repairs, that placing a piece of mesh in the groin is not going to cause harm or increase your patient's risk of chronic pain. But we know that this conversation around mesh is one that you have to be able to have transparently with your patients, especially with all of the discussion of mesh being, overall a risk or a bad thing for patients. When we talk about seroma formation, I think that's something that does come along with mesh placement, and especially with a posterior approach. There's ways we can reduce that. I'm a non-fixer. I think that larger sizes can, and I do think that direct hernias can propose people to larger seromas. I set the bar really low, and I tell people you are likely going to develop a seroma, or you may develop a seroma, so they can be prepared. With large direct hernias, I think that the robot does really help you be, all-encompassing if you want to imbricate that hernia sac. But either way, you can still develop hernias, and it should be something that's discussed. Obviously, how you're going to fixate your mesh may be something that's adding the risk of this occurring. Overall, and again outside the scope of this talk, is know your prosthesis. These are the, for the most part, the mesh and the suture that I use. There are lots of different options out there, all with their own, pros and cons. I think that the ultra-light wet meshes in the groin, certainly are fraught with higher recurrence. But other than that, if you know what you're using and you're using it well, then you're probably doing the right thing for your patient. Then we come to the whole discussion of open versus laparoscopic. And I think that there are a lot of studies that have come out through time over the last 10, 12 years, or 10 to 15 years, showing us that laparoscopic does have benefit. It has benefit of recurrence, perioperative complications, postoperative pain. There is a benefit from doing our minimally invasive approach to the inguinal canal. We feel good and the patients feel good. This was a study done showing patient recorded outcomes, and patients do enjoy the increased ability to get back to their activity. Pain perceptions have also been looking into. Bittner kind of really did try to allude to an acute postoperative groin pain, and did, although he teased out robotic and lap, it seemed to be the minimally invasive approach that tend to propose people to less activity disruption and less acute pain after surgery. So then what do we do with the other side? And that's something that we're always trying to see, because once you put it in the scope, you are going to see if there is a hernia on their side. Some patients have peculiar symptoms. These are a few studies that I think are letting us know that overall it's safe. Patients will do okay with a bilateral repair. Should we do it prophylactically? It's not something I've embraced into my practice. If I see a hernia there, I fix it. I don't explore unless someone has symptoms. But these are all discussions I have with patients prior to surgery, because there is evidence that would support a higher risk of postoperative complications, namely bowel obstruction and seroma, that could be at the detriment of your patient. Again, patient preparation being the most important. So here we come into the robot, and as Dr. Jacobson alluded to, I trained in MIS here. At that point, we were not doing robotic inguinal hernia repairs. I went back to Canada, where we don't use the robot at all for the most part in general surgery, possibly colorectal. But when I came back, the opportunity was there for me to learn how to use this fancy tool in the inguinal canal. And I must say, it really did enhance visualization for me. It really gave me an opportunity to see the anatomy that I may have struggled with in the past, that I saw quite clearly laparoscopically, but really to kind of push the avenue of what I'm seeing and what I can do. Here you can see the SI and the XI console. When I first started, I was side docking that SI, no complaints, I didn't mind. Now I'm so in love with the XI, if you handed me the SI, I'll complain for the full 45 minutes. But either way, great tools, and these endo-wrist instruments allowing for just great exposure and manipulation in the groin. The force bipolar is a complement to the XI platform, which I really enjoy. I like having the opportunity of the dual grip, and obviously having another energy source is helpful for your dissection, especially if you get into any bleeding that needs immediate control. So as we get into the surgery, and I had to kind of scramble to put together a video because I wasn't going back into the hospital, we talk about preparation. I'm going to go through a little bit of things I do, probably similar to a lot of the hernia surgeons here. You may pick up some other points from other lectures that you can apply to the inguinal canal. But for the most part, preparation for me involves me standing with the patient in the pre-op area and making them void. I don't prophylactically put in a catheter. I make sure they use the washroom before they come and roll back into the room, and I think all the nurses know that that's kind of the way things need to go. I do believe being proactive can decrease the risk of urinary retention, and we'll see how my data lines up accordingly. Patient positioning, they're flat on the table. I like to say I'm going to tuck both arms, but I must say if anesthesia are going to put in another IV, I just tuck one arm, and that usually makes everyone happy. The ports, I didn't bother with an illustration because it's very standard. I do an open access at the belly button, 8mm trocar, one other 8mm trocar on either side. And with the robot, I just go a little bit higher, a little more cephalad with those lateral ports than I do my laparoscopic ports. But for the most part, it's pretty standard placement. The docking becomes an issue if you're going to use the SI. I must say if you wanted to really simplify and you haven't done a robotic repair, the XI just makes it so easy for your nurses to be able to drive it in. If you're going to use the SI, it's no problem. You just have to side dock it, almost like parallel parking a car. You just side dock it, and then you can carry on with the operation. Now the instruments depend on which console you're using. With the SI, you're kind of committed to maybe having to grab an extra instrument. I tend to start with the Maryland and the Met, and then I'll bring in a needle driver if needed. But if I need a stronger grip on those big hernias, then I grab the ProGrasp. The benefit of the XI is I do like the dual grip of the force bipolar, and for the most part I can keep it then to 3 instruments. So going back to, the critical view of the myopectineal orifice, and also, these 10 golden rules, all ways that people have very nicely articulated their approach to the inguinal canal. These are things that I'm sure my residents, because I like to teach the residents on this platform, these are my 13 crazy things that Dr. Chevry probably says a billion times in the operating room. And as we go through a video, I'm going to try and allude to when these comments tend to come up. I'm just going to sneak out here for a minute to pull up a video. So for the most part, and this is a 4th-year resident that's doing this operation, and I usually just dance around in the corner sometimes with the marker with my 13 weird things I say. But I start laterally, and I try and get them to just stay high. That's what you'll hear me saying, straight across, straight across. I find as a learning curve here, you can see this resident, he wants to duck down here. And as part of our rules, we want to stay well above, 4 centimeters above where our defect is. This is not a big hernia, so I don't think there's any problem, but this is where I'm kind of telling him, you can see, get up, time to get up. You can see our vessels coming into view, but that's one of the things I think is important is keep your horizon flat, head straight across until you get to the medial umbilical ligament, and then you're going to head up a little bit. Very similar to what your laparoscopic approach would be like. This is where you'll definitely be hearing me say, now it's time, if you're going to continue medially, no problem, but it's time to dig a hole, and you need to use that left hand to pull the bladder down. I keep telling them, you've got a robot now, so you can really turn yourself right into the corner to dig this, and this is what I'll be telling the resident. You can get right down there. We want to see across midline on that pubis, and this is where we're getting into, is the retropubic space, or the space of rectus. And it's important to be able to see this clearly to get adequate coverage when you do place your mesh. So this is, the resident kind of hearing me say, keep going, keep going. Laterally, one of the things I keep saying is use your instrument, the scissors here, like a snowplow. I know we don't have much snow here in San Diego, but I did a lot of it, and you want to use it like a snowplow to push down the side. And here you can see it's very easy to go anterior into the abdominal wall. You got to curve down around into the pelvis, or you are going to pull down that intermediate layer, which we're pushing away here now. Laterally, you want to keep that, second layer or invested layer of transversalis fascia. You want to keep it on the anterior abdominal wall, almost to protect the nerves. And this is where, we didn't quite accomplish that here. There's always going to be a bit of a bridge if the planes are slight, but that's really a point, is to keep that covering here. Here we're going to, again, use it like a snowplow. We want to stay on the peritoneum. Now you can see the vessels are getting dissected away. Choking up on the peritoneum is one of my other things. Choke up on it. You need to kind of really have that nice sensation of when you're pulling. This was a little bit aggressive, but I think he liked the fact that I was trying to tell him use controlled, nice movements. Didn't mean necessarily to kind of pull the structure off, but the tissue will want to give when it's in the right plane. Now here you can see he doesn't really know where this is yet. He wants to go low, and I'm kind of alluding to the fact, stay up high. You need to get the vas down. It's sneaky. This is a small hernia, but with the robot, you can see everything. So I try and tell the residents there's really no margin for error here, because the visualization is exceptional. So he's taking his time here. I also think it's important, keep the keep the vessels with the vas deferens. So that's what I'm trying to get at the resident here. So he's making finally an opening. Once you have this window, I think it's not unreasonable, although this next maneuver I don't usually do, transecting the sac. I usually give it a go, but the resident here was feeling very good about himself. He had demonstrated that he had, dissected out all of the pertinent anatomy, and I believe that was reasonable at that time. I don't think it really contributes to much more fluid collection. This is where I start to tell the residents, or I tell myself, this can wait for later. Getting finicky down here doesn't really matter right now, because I'll save that for when I have 2 hands. Now going to a contralateral side, I still tend to work, because I don't like to switch my arms, the instruments. I'll just work medial to lateral. So I have to cross this left hand over to really expose by grabbing the medial umbilical ligament and really expose for myself that same space. We're going to go all the way laterally towards the level of the ASIS, staying up high. Again here, we want this invested, or this intermediate layer, to stay covering our nerves. This is a pretty small defect, but again, the principles are the same. I want a bilateral repair to have connection behind. I don't drop down the bladder completely. I kind of leave that bridge of tissue there. Here's again where I'm telling them, use the robot. You can see clearer than that. And now we can get into the other side of our dissection, really opening up that space so we can have adequate coverage with our mesh. There's no reason not to see everything. Once you're gone medial, although it gets exciting to just carry on that way, it's important to come and finish your lateral dissection. I use the ProGrip mesh, so I don't like anything sticking to the mesh more than it needs to, so making sure I'm complete in this dissection. And here we're just kind of, this is why I always tell the residents, you're kind of picking now. You're just kind of picking. You can be more deliberate, and if it's not working on one side, same as my laparoscopic approach, I can always flip it over and see if the tissue plane will give a bit on the contralateral side of the hernia. I'm going to move this along a bit here. This is a pretty small hernia, but here you can see nicely the vas is going to drop down. The vessels have dropped down. And you're just working at a little bit of tissue here. I kind of move this along. There's always this sling. Everyone kind of fights with this little sling of tissue. You know, that's pretty common, and sometimes you have to cut it. Here we got too aggressive with that move and made some holes, but I don't really care about that. We're going to talk about that after. Choking up on the peritoneum. You can see the structure so clearly. There's no reason not to. And here we're just going to complete dissecting that vas off of the peritoneum to complete the reduction of this hernia. I'm going to move it along here for the sake of time. We've almost got that pocket. This is where it's hard not to take over, but I try and really let the residents do as much of the operation in a progressive fashion during their short time on our service so they can really appreciate the anatomy. It's one of the true benefits that's difficult to prove data-wise with the robot, but the clarity of what you're seeing, I think, has yet to be matched, even with the best laparoscopic platform. Let's move this along here. This is a small defect. Completely reduced, I insert both meshes. I used to try and save time by inserting the meshes and the sutures all at the beginning. There are lots of people that do that, that it would save time. I'm honestly just too paranoid about suture flying into the upper quadrants of the abdomen, so I will take that extra little bit of time. I'm also teaching, so time is relative. I think this is important when we talk about the steps of proper coverage. I use a 16 by 12 centimeter mesh, just tailored at the corners. I let the resident kind of battle along here for a while, but eventually he had to realize that the whole mesh had to move over. I always say shuffle the mesh. And people kind of want to move it a little bit, but you're going to see sometimes you have to pick up the entire mesh to get it all the way to midline, and that's what we're, you know, kind of struggling with here because I'm just not happy until it's actually covering. And it's funny that the residents learn by letting them do it themselves. They realize you can't quite accomplish it with a little move. Sometimes with these meshes, you need a big move to get the effect that you need. So here now I'm happy. We're to midline on the pubic ramus. I think it's important to have the mesh flat. There's a move where I like the residents to push in with their opposite hand to get more space. Rarely, if you pick your optimal line of peritoneal dissection, should you have to dissect upwards on the anterior abdominal wall. This is where I tell them to wait till later, or I tell myself, I'm going to get 2 hands in there, so if there's something that's not dissecting perfectly with scissors, I just wait till I get my mesh in there. This is me, the annoying person with the marker that's during the operation, this poor resident. But I'm showing him where to grab it. I can see so clearly where it's inserting onto the peritoneum, and you know, you have such precision now with 2 hands in there, and you have to complete this groove. This groove for your mesh to lie flat, especially in those narrow male pelvises, it's important. So I'm going to make him work at this, and I'm kind of showing him, no, you got to get this all opened up. Obviously, we're not going to get into any big vessels that make anesthesia excited. But you have to open this all up. So I'm just kind of showing him where to go, but really just not letting him stop until I see it opened up completely. And he's almost there. Here's me saying, no, stay away from the vein. You want to be over here. And there, you get 2 hands in there and open that right up. Now the scope of this to look for different defects, I think everyone can find some awesome videos to explore the different, femoral, direct, indirect spaces. But obviously, here would be our direct space, our indirect space, our femoral space sitting more inferior and medial. Now he's getting fancy, still not quite in the plane, but you can see the perineum coming up there and me telling him, so close, yet so far. I desufflate to a pressure of either 5 or 8 as I lay out my mesh. I like the no fixation with these absorbable hydrophilic prongs. And here you can see where I want it to, again, lay flat. I think one arm holding up and then starting to unroll it downwards is useful. You can just be so precise with the maneuverability of the robot that there really is no reason to leave this operation without it looking pristine. Once it's all the way up, I think a nice, if you can be controlled, is use one hand to support where you want it to not move. You'll get more space, especially when you're desufflated, to really unfold that mesh in as much of a 3D position as you can. Suturing the perineum, I think that people get excited because it's a lot of suturing. The robot makes it so fun to do. I agree with that. But this is a point in the operation where you can gain speed. This is no more than putting one piece of tissue to the other side. So I try and not, I try and encourage the residents to get into a momentum here. Unfortunately, this resident, I think, broke the suture on both sides. He did such an awesome operation, and I think I had to almost penalize him at the end. But at the end, I kind of took over and just did a T closure. I call this my quilting 101. If you make holes in the perineum, no problem. Be creative on how you're going to close them. Creative meaning don't ask for a whole bunch of really expensive sutures. After my Stratafix, unless I have a huge opening, I'll ask for a vicryl. I do close small holes. You can get awful outcomes of obstruction and weird and wild things of things sticking in small holes in the perineum, and that becomes no fun at all. All right, so let me get out of here. Okay, so that is going to take me back, and how am I for time? Okay. Okay, I'm almost done. So those are all the things that are kind of like my version of steps that make it safe and a good exposure. Perioperatively, one of the benefits I noticed with how we're approaching our minimally invasive repairs at UCSD is, and other places as well, is the need for post-op narcotics. I give none. I try and supplement this kind of a regimen pre-op, intra-op, and post-operatively, but I try and avoid narcotics in the post-operative setting, and so far I've been very successful. So then we get to kind of a side topic as we're talking about, the right approach to the inguinal canal. What is with this fancy tool? Is there a benefit? And, unfortunately, there's mixed evidence out there now. I think that it's important for us to understand what tool is appropriate for the right patient and the right surgeon. There's some evidence saying that there is no outcome that was really that significant. There was a study that also showed, well, this is a great learning curve. You can take on this new tool and you can very quickly get your speeds up. There obviously are limitations with these studies on how they are done, their sizes, and what surgeons they're addressing. This is a newer paper released from the large clinical database showing good outcomes when you talk about the robot, showing benefits of the robot with regards to infection and perioperative complications. That being said, there's also a little bit of this is already kind of a dictum that maybe there is no difference whether you're doing open, laparoscopic, or robotic. Maybe your pain is going to be the same no matter what. A little bit contradictory to what we've learned in the past, but people are kind of, going to keep asking questions. As recently, the rival RCT, it came out actually showing that robotic surgery is going to be increased OR time, increased cost, increased frustration. So at the end of the day, I think that we have to figure out, what are we doing? We can talk about this in a negative way, but if you look at what we're doing as a nation, we're doing a lot of open inguinal hernia repairs. And if you buy into the data that I presented earlier, we know that there is a benefit to doing minimally invasive approach. I think one area that is difficult to tease out are the learners, the people who have been doing open surgeries forever. How do you get them to jump on ship to a minimally invasive repair when the tools to do laparoscopic repair, I believe, are challenging? It's challenging to see, challenging to do. Therein is a role for the robot, because there's no question the enhanced visualization and that ergonomic benefit to those wrists. In addition, teaching residents, I mean, I do think they need to have a laparoscopic appreciation on everything they're learning, but the robot certainly is allowing me to let residents leave my service doing a full inguinal hernia repair. So that's a very small glimpse of what I'm trying to appreciate of robotic inguinal hernias and where things are moving, and I'm just really thankful for the opportunity to be able to be a part of this webinar.
Thanks, Delphine. So I've seen some questions rolling in, and I didn't quite realize that I probably should have been bugging you as you went along. Someone asked about mesh fixation. Can you comment about the ways that you?
So for me, I fixate only with the Pro Grip prongs. I've kind of lost the webinar here. If I have a large direct hernia, I will place a vicryl or an absorbable suture medially, not at the pubic ramus itself, but in some of the soft tissue to keep it from slipping. But those are the patients where I also focus on having a very good overlap, really getting the mesh all the way across. So I think that the fixation could be a skill preference, but with the robot and with suturing, I think we can get away from tacks. I've never been someone who's even trialed glue. I don't know if I will. I think I'll have to see some people do it. I'm kind of a little bit wary of that, but that's kind of what I'm sticking with, is the Pro Grip and then absorbable sutures as needed.
Yeah, so that's great. And so if you're not using fixation, I mean, certainly the conversation about fixation is a long one. And I hit all the key points. We do have a SAGES sage commenting on Dr. Ed Felix has joined us and said, what about cord
lipoma? I kind of left out because, you know, it's similar to what I would approach with my laparoscopic repair, but I think it's important. I think it's actually imperative to detect these lipomas. It's easy sometimes to confuse a cord lipoma with either cord fat or even anterior abdominal fat, but a true lipoma should be looked for and dissected out. You don't always have to remove them. I remove them and take them out of the body if it's impeding where my mesh is lying, but I think if you leave a lipoma there, you're talking about more recurrence and ongoing chronic or ongoing growing pain that has not been addressed with the surgery. So I think lipoma detection and dissection is important.
Great. And how about utilization of robotics for resident teaching? It seems like you let the residents do quite a bit.
I do. I really think I'm trying to actually fall off the coattails of a urologist I was speaking to try and construct a true teaching platform where they can really come in and break it down into steps, and how we can really have them leaving feeling like they're really competent. Because if you can do it, that means you've seen it. It's just difficult in our program to really construct, but it's something that I think is really important. So I'd like to move forward with that for sure. I see it.
Great. These are great questions coming in. I've really enjoyed them. We're going to get going with the next talk, and I'll try to bring in some of the questions as we go. So next up is Conrad Bowser, who really has been on the forefront of robotic hernia repairs. He's been in it since the beginning, and was probably one of the busiest private practice robotic hernia surgeons. And I say was because we finally convinced Conrad to join into the academic fold. And he's recently accepted a position at Creighton University where he'll head up their hernia program and do all of his other great stuff. Conrad's really known as a hernia surgeon that other hernia surgeons go to for advice on the robot. So I was just really excited to have Conrad with us, and he's going to talk to us about complex robotic ventral hernia repair. So I look forward to this talk as well. Thanks, Conrad.
All right. Thanks a lot, Garth. I'm super honored to be invited to this forum. This has been tough on everybody. If anybody knows me, they know I love to teach, and no one I'd love to teach more than residents. So this is an awesome forum. I'll be talking about complex robotic ventral hernia repair, and just like what Dr. Jacobson said, I did make that big move from private practice into academic medicine just so I can have the possibility of being able to train residents 24 hours a day, 7 days a week. This is my facility. It's Creighton University Phoenix Division, and what's kind of cool about this, I was born right here where the star is showing. I did some research here after college. My dad is an anesthesiologist. He used to work here in the ORs, and that's where I currently work. And this is my office, so it's pretty cool that my life has gone full square going forward. These are my disclosures, and it's been awesome to see this amazing exponential adoption of the robot in the ventral hernia space, a space that's pretty sacred to me given where I've come from. And one of the reasons why I think this space has been so valuable and the adoption has been so high is because it allows other options to be executed in order to tailor your hernia repair on a patient-to-patient basis. These are the three approaches that I'll be talking about today, kind of giving you a bird's eye view of my complex practice. And again, it allows me to tailor my operation through a spectrum of hernias that range from the benign to the absolute horrendous. I trained at Greenville, South Carolina. That's where I did my MIS fellowship, and this is what we did. We did laparoscopic IPOMs, and for the first 2 years out of fellowship, this is what I did. Lap ventral bridge IPOMs. And the data was great in this in terms of recurrence, but I was becoming increasingly dissatisfied with the persistent bulging because we failed to address the divarication of the rectus muscle complex. The patients weren't particularly happy with the cosmesis of this minimally invasive procedure, and they certainly weren't happy about all the postoperative pain due to the circumferential tacks and full-thickness transfascial sutures. And I was becoming increasingly reticent about the fact of leaving foreign body exposed to the visceral content that can rarely result in vivo obstructions or fistulas, but maybe not so rarely impact every future subsequent surgical intervention of that patient. So because of this, me and many others started to do more open hernia repair. I essentially abandoned my lap ventral practice. We would sacrifice the additional trauma to the abdominal wall to deliver what we thought were better repairs, extraperitoneal hernia repairs, through big open incisions. But as we all know, there's attendant risks to whenever you open up a patient, and especially those who are poorly optimized. So the robot, what the robot did for me, it got me back into the MIS space in terms of ventral hernia. Like I said before, I'm going to start this talk off talking about tap ventral. This is probably about 50% of my ventral hernia practice. And I remember when adopting the robot, I wanted to be able to figure out a reproducible way to perform extraperitoneal hernia repairs. And we said, well, if we tap the groin, why can't we tap the anterior abdominal wall? So these are just little tips and tricks. I always say that fat is your friend. Those are areas of peritoneal dissection that are relatively straightforward. But as you move laterally underneath the rectus abdominis, so usually at the level of the semilunar line, that area becomes very thin. And I think a lot of surgeons struggle with this. And it's all about learning how to handle thin peritoneum. It's also about understanding the different layers of the abdominal wall. There's a pre-peritoneal layer and there's pre-transversalis fascia layers, which you can exploit, in which you can make a big pocket. And the way I do that is I buzz a little bit of the posterior sheath. It's a retract, buzz, and push. And then that will get me into a thicker layer, allowing for a more robust posterior element or peritoneal element in which I can make a big pocket and eventually place a large piece of mesh hidden from the visceral content. So this is just a little bit of a montage on some of the stuff that I offer. This is a guy with a primary umbilical hernia. He also had an unrecognized epigastric, which is also nice when you compare it to conventional lap IPOM. You start uncovering defects that you otherwise wouldn't have seen if you didn't take down the peritoneum. So I like to dissect on each side of the hernia sac. That allows me to create what I call the volcano sign. And then I continue on dissection, and I don't stop until I reach the contralateral transversus abdominis. You can see here it's a thicker plane. I'm in that pre-transversalis plane, which will become important once I talk about the more complex robotic techniques, but that's a very reproducible plane to get into. And when you make a big pocket, it renders these small holes in the peritoneum negligible, because you won't see that after desufflation, and it'll also allow for you to reperitonealize your mesh. So this guy had a little bit of diastasis recti, and I don't plicate every diastasis, but when I do, this is how I do it. I take a big bite of medial rectus fascia, a little bite of attenuated linea alba, and then a full thickness bite of the opposite linea alba. I'll utilize the same suture to primarily close the defects, and then I'll put a large piece of uncoated mesh with minimal fixation, and then ultimately hide that mesh from the visceral content. You can also use this technique for other approaches. This is off midline hernia, atypical by definition. This is from a trocar site after a lap colectomy. You can see all the fat here. That area is easy. You can also notice that one thing that is super important, that your grasper and your scissors are always working in concert. They're always working on top of each other. That's one of the main tricks that I tell my residents when conducting cases such as this. So you get a big preperitoneal dissection that allows you again to place a large piece of mesh, and you allow the mesh to incorporate on both bases, so you fixate it minimally. So this is a dude with a lot of abdominal hernias. He had a recurrent suprapubic, he had an ileostomy site hernia, he had an arcuate line, he has a left lower quadrant trocar site, and he had bilateral inguinal hernias. So my goal was to completely open up the peritoneum in the spirit of Stopa and mimic his giant prosthetic reinforcement of the visceral sac. I can reduce all the hernia defects, as you see here. That's getting into the space of rectus. I'm doing my inguinal hernia. He also had a low spigalion on the left side that you can see here. I observed the critical view of the myopectineal orifice, and then I can primarily close the suprapubic, the ileostomy site, the trocar site. I don't close any defects in the groin for risk of potential chronic pain and nerve injury. I'll fixate this one single prosthetic to the pubic bone, and then I close up suture the mesh. Like you can do hernias low in the abdomen, you can also do hernias high in the abdomen. This is a lady with a very large Morgagni hernia. I'm reducing the entire transverse colon as well as the omentum from her chest. Now I've done these in fellowship, and all we did was we would reduce the hernia and we would patch that up with a big piece of PTFE. We would do minimal fixation. Now I treat this kind of like a direct inguinal hernia. Completely or preperitoneal dissection. I will dissect all the way to the central tendon, as you can see here. I'm also a big believer in adhering to well-established principles. I was trained to use Ethibon on the diaphragm, and that's what I've continued to do, although I'm sure you could use VLOC there. And now I reinforce the repair with a big piece of mesh hidden from the visceral content. So some of the benefits of this R-TAP approach, it's reproducible. I think that tap that has become quite common in many, in the vernacular of many surgeons across the United States. And not only is it reproducible, it's versatile. And I say you can essentially do this for any hernia in any location, not requiring a component separation. You have the ability to use an uncoated versus a coated mesh, which comes at a measurable cost savings. And you can also transform a surgery that was used to maximal fixation and now is minimally fixated which certainly benefits in terms of postoperative pain. And I think I'm doing my part to minimize the exposure of the bowel to foreign bodies, as you can see here. This is my data. I've done probably 410 of these now at last check. The opera time is relatively minimal. These is pretty much all outpatient surgery. But I think most remarkably, and in contradistinction to my previous lap IPOM cohort, they return to work, they require fewer narcotics, and they return to work at a much earlier rate. So as we progress the increasing difficulty along that spectrum of approaches, I think we have a lot to thank Dr. Yuri Nowitzki for pioneering this TAR technique. And if anybody is aware, this is kind of the buzzword worldwide and becoming the go-to of many surgeons around the world. We're in the process of publishing a paper, Critical View of TAR, because what we're seeing, and I'm sure Dr. Jacobson sees a lot of incorrectly performed TARs, whether that's being performed open or laparoscopically or robotically. So just to give you a little bit of a hint, this is the classic Reeve stopa. We have the posterior sheath dissected off of the rectus abdominis muscle. We've dissected all the way to the semilunar line. We've isolated and preserved the neurovascular bundles. I like to start the TAR procedure down low. And what you want to know, your posterior elements should not have any muscle on it. So the reason why I like to start low, I like to start where it's fatty. It's easy to dissect the posterior elements when it's fat. Again, fat is your friend. What you want to see on the lateral abdominal wall, the arching transversely oriented fibers of the transversus abdominis. So the way I start this, the landmark is the arcuate line. Below that is transversalis fascia. Similar to a tapping inguinal, you can incise that transversalis fascia, the two leaflets, and get into the true preperitoneal space. So the tenets of bottoms up is not just doing a TAR from down to up. It's about building this preperitoneal cave that I like to talk about. Separating the posterior elements of what you're trying to preserve from the anterior elements, that being in the lower abdomen the aponeurotic transversus abdominis, which we will eventually divide. Medial to the semilunar line, medial to the neurovascular bundles. When you approach the low to mid abdomen, you start losing that fat. That fat becomes more retroperitoneal in location. Your posterior elements become thinner. And like what I was talking about, the tap ventral, you can transition between the true preperitoneal space to the true pretransversalis space. The way you recognize that, you can start seeing naked belly TA on the abdominal wall, and you can see a thicker posterior element that you are dissecting off of the lateral rectus sheath, or posterior rectus sheath here. This arrow delineates your vector of dissection. I'm trying to get that transversalis fascia off of the naked belly of the TA muscle. As you see here, as you approach the mid-abdomen, that's where the transversus abdominis starts inserting more medially on the posterior sheath. So you start dividing actual muscle fibers. Again, you want to divide medial to the neurovascular bundles, as you see here, and eventually you get this full dissection from down in spacer rectus all the way to the level of the central tendon, exposing the TA, the diaphragm, as well as the costal margin. This is what I call the sine qua non of TAR. And if you don't see this, and I don't care if you're in there endoscopically or open, if you don't see cut edge of TA on the abdominal wall, cut edge of TA on the posterior sheath, that means that you are in the wrong plane and you run the risk of a semilunar line injury, which can be fairly devastating to the abdominal wall. This again is what you should see. Cut edge of TA on posterior sheath. You should not see any muscle on your posterior elements, and you should see cut edge of TA on the abdominal wall with preserved neurovascular bundles. This is the same thing that you should see open. This is when the visceral sac is closed open. This is when it's closed endoscopically. This is what you shouldn't see. Again, this is TA on the posterior elements. This is a cut edge, probably the internal oblique. That is pathognomonic for semilunar line injury, which again can yield a lot of problems going forward. So here's a video of a guy He's from Florida. He was sent to me He didn't have a huge hernia, probably about 13 centimeters wide, but his hernia relative to his non-compliant abdominal wall was fairly significant, so I actually Botoxed him preoperatively. So I'm doing retromuscular dissection on the patient's right side. I'm dissecting to the semilunar line, and then this is in the lower abdomen. I do my suprapubic crossover where I get periperitoneal. Dividing transversalis fascia like I was showing you in those images, making that periperitoneal cave, as you can see here. And this is how I work under that lateral posterior sheath, digging that cave, preserving those posterior elements, not making any holes in those posterior elements, which can certainly add to the length of your case. That's division of the aponeurotic TA in the low abdomen. And when we get to the mid-abdomen, you'll start seeing that start to become thicker as well as muscular. Delineating, you're starting to divide the muscle layers. Now this is me transitioning between the true preperitoneal space to the pretransversalis space. You can see I'm starting to dissect muscle, and I dissect all the way to the retroperitoneal fat like you see here. There's the TA muscle, that's my line of division, which is medial to the neurovascular bundle. My retraction is cephalad and medial. That's getting to the epigastric area. This is how I do the top down. I kind of do the same thing. Develop a cave, go preperitoneal, and then I just connect the dots. You can see I'm telestrating for the resident to complete that portion of the case. See, I've achieved that sine qua non that I was talking about. And I place my mesh. After I'm done with one side, I do a lap-guided tap lock, and then I perform contralateral dissection. Retromuscular dissection going into the groin. This is the transversely oriented fibers of the TA. That's exactly what you want to see. You don't want to see any muscle on your posterior elements. Vector of retraction, again, is cephalad and medial. That allows me to see the preserved posterior elements. Dividing the TA muscle, that's the retroxiphoidal dissection. That's the retroxiphoid fat pad. And just trying to get that visceral sac all down. Once I've accomplished this, I close the posterior sheath with the running to a vicryl. I do it in a canal-like fashion. It's efficient, and it also hides the barbs, which have been associated with adhesions and bowel obstructions. And then I use number 1 V-lock to close the anterior sheath. I'll take some bites of the dome of the defect. You can see how the rectus is back in the midline. You can see that before and after. And this is my suture trick to unroll the mesh. You can see I still need more mesh down in the low abdomen. So that was a 30 by 30 sheet, and this is another 30 by 15 down to cover the groin, oriented transversely. That's Arista, and I use glue, and then I use drain just to help mitigate for hematoma as well as seroma. This is him on post-op day 1. You can see he's got the front butt there. A lot of people were worried about that look, but I guarantee you that look goes away within a week to 2 weeks. He was discharged on post-op day 1, which truly became a game changer in terms of being able to recreate. See, this is him post-op day 4. That front butt is pretty much almost gone at this time. So I was really scared to venture into that ETEP world. I had no previous TEP inguinal experience, but thanks to Profs. Diaz and Beliansky and Dr. Pearson actually proctored me doing my first few ETEP procedures. I learned how to do this case, and there was certainly a deficiency in my practice. A lot of times I would still do open reeve stopa, and this is an amazing repair. It's actually one of my favorite open ventral hernia repairs out there. But I'm a big believer, if you don't have to cut the posterior sheath, don't do it. So I typically reserve these type of hernias for hernias that would be difficult to do a dissection on, somebody with long midline incisions, somebody with Swiss cheese defects, or like an umbilical hernia within a large diastasis where a retromuscular approach seems to make sense. A lot of people ask who you tar. This is my mentor, Alfredo Carbonell, and he came up with this Carbonell equation where based on CT, if you add the sums of the recti width, and if it's 2 times the length of the actual hernia defect, a Reeves Stopa will be okay. If it's not, he progresses to tar. I try to make that math a little bit more simple. I add 10 to the maximal width of the actual defect, and if that size does not fit in the retromuscular space, I will do a tar. So before about getting access to the retromuscular space, I used to do ultrasound, but Igor Belyansky taught me a nice trick where he'd go 2 finger breadths below the xiphoid right in the midline, and then he would draw a line all the way to the costal margin. And that's the point where he would place his trocar for initial access. There's different ways you can dock. You can do upper dock and go top down, or you can do a lateral dock and go from the side. You can also do a lower dock. I haven't done that yet. I don't want to risk collisions with the legs, but I know a lot of surgeons have had great success with that type of approach. But essentially, once you gain a retromuscular access optically, as you see here, you want to dissect that retromuscular space. Once you've dissected the retromuscular space, you got to incise the posterior sheath to do the crossover. And what we're incising here is the posterior sheath contribution to the linea alba. And then you do preperitoneal dissection, leaving that peritoneal bridge, which is a little bit of a departure from the classic Reeves retromuscular hernia repair. And then you dissect it all the way to the semilunar line. As you can see here, you can do a tar from this ETEP perspective. And then once you've dissected the retromuscular space, you primarily close the defect, so you get the rectus back in the midline, and then you can put a large piece of mesh within that retromuscular space. So here's a little bit of a montage of some of the ETEPs that I do. This is a guy with incisional hernia, long midline incision. You can see, once I see the muscle, the red of the muscle, I drive my laparoscope and then I just start dissecting that retromuscular space. What you don't want is to go through the posterior sheath. You want to be careful when you place trocars. This patient I did a side dock on. And then I chose to cross over in the lower abdomen. I think it's easiest to cross over either in the lower abdomen or the upper abdomen here. You can see there's no diastasis because once I did that, I'm already in the right retromuscular space. This, I'm going around the actual defect. I'm using a cold cut. I didn't do an intraperitoneal peek, so I'm not positive that there's bowel in there. That's the thing that scares me the most. So most of the time, I actually get an optical entry. I look intraperitoneal, and I make sure that there's no bowel within the hernia sac. So I dissected to the semilunar line, all the way to the space of rectus, all the way to the xiphoid process, making sure I have enough overlap over the entire incision. And then I just primarily close the defect. Rectus is back in the midline. And then I'll just close the holes in the retromuscular space. Usually it's a hole in the peritoneum. And then desufflate and done. This is a top dock approach, a multiply recurrent incisional hernia. After 2 failed lap IPOMs, you can see bowel coming out of that defect. So I did an intraperitoneal peek. Once I insufflated, you can see from that trocar, I took a look inside, making sure that there was no incarcerated bowel in the sac. So once I see the red of the rectus, I drop my laparoscope, and then I just start dissecting laterally to semilunar line, medially to linea alba. And I'll just make these wide sweeps, riding right on top of the posterior sheath, as you can see here. So when I do a top-down approach, I have to place another trocar to give myself another hand. I'll either use a hook. Here I'm using a ligature. What I want to do is I want to cross over with straight sticks so I can place my robotic ports. The top-down approach is kind of nice because it offers a different perspective than the side dock approach. You can see I'm opening up the left retromuscular space here. And once I have enough room to use my trocars, we can dock the robot and then we start with our retromuscular dissection. Again, division of the left posterior sheath, dissection of the right retromuscular space, and these are the three retromuscular spaces that you can see all at the same time, which is a comforting look in that TEP space. You can see the left retromuscular space, the pre-peritoneal space, as well as the right retromuscular space. So here I'm approaching the defect. It was non-reducible incarcerated, so I had to actually open up the fascia a little bit to get the incarcerated omentum down. Now I'm pretty aggressive with these strokes because I know that there's no bowel in there. I reduce the omentum back through the sac, and then now I have to dissect further. So I encountered the previous IPOM meshes there, and it's I get questions all the time. Do I leave that mesh? Do I leave that mesh? It really all depends on how much posterior elements you have to exclude your repaired mesh. I preferably always like to take that mesh out along with all the spiral tackers if I can. These two pieces of EPTFE mesh, that's going to the lowest Swiss cheese defect. And you can see now I'm just going to dissect in order to attain enough caudal overlap. So I'm removing the PTFEs. I'm closing the posterior elements. I want to make sure that that comes together without tension because there is risk of posterior sheath dehiscence here that results in fairly acute recurrences of hernias. I do one suture right to pubic symphysis. This is a 20 by 30 centimeter sheet of mesh. Again, Arista, drains, and that patient leaves on post-op day 1. This is my robotic retromuscular data. I probably have 112 now on last update. Certainly, I've had complications just like any other surgeon. I'm sure I've had more recurrences than what I'm reporting here from some of my patients going to other surgeons. But one thing that's unquestionable is the length of stay and the decrease in postoperative pain. So my advice to you guys is to learn to build your armamentarium in order for you to be able to tackle a spectrum of pathology on a hernia-to-hernia basis. This is my demographic information. I love talking to surgeons and residents from all around the world. You can always find me on the International Hernia Collaboration. Feel free to shoot me a text or email if you had any questions. I always love to help out. And just to leave you with a word from my chair, this is Professor Ron Galliano, and he said, and I quote recently, save one person, you are a hero. Save thousands, you are a doctor. So take pride in what you do. Be safe out there, and thank you very much for your time.
Thank you, Conrad. That was really, truly an outstanding talk. A couple questions from the audience. One, how often are you using Botox, and when do you do it?
So most of the times I use Botox. It's not giant hernias, but it's high volume hernias relative to the size of their abdominal wall. So it's a lot of skinny muscular patients where I want to increase the compliance of the abdominal wall. I Botoxed a patient with a 7 centimeter defect, but she had a BMI of 18 and she was very fit, a CrossFitter. And I didn't think that there was any way that I could get her back together otherwise. So I probably used it a total of 5 times. You know, it's interesting to note, it seems to have worked, but it's hard to study because you don't know what would have happened if you didn't use it. And I think that's the main problem with Botox. One thing that I have noticed, though, is that their postoperative pain is even less than those that I don't Botox. And I think that's been well reported in the literature and findings of other surgeons reporting on this.
Great. And another question is there ever a situation where you can't get those posterior elements closed? And if so, would you change your mesh choice?
So I did an ETEP procedure on a multiply recurrent incisional, in which I had a lot of difficulty. I was having a ton of holes in the peritoneum. What I ended up doing, and I was trying to close the holes. And the problem with trying to sew thin peritoneum, you run the risk of actually making those peritoneal holes larger. So what I did was I covered it up with a sheet of new knit. I've seen that done before. And then I placed my uncoated mesh on top of that. No data at all to support that, but that was a bailout to maneuver on my part, for sure.
Great. Well, I think that was a really great talk. I know there's more questions. Time's getting away from us a little bit, though, so I'm going to jump over to Marcos Nicolati next. Marcos is a minimally invasive surgeon at Loma Linda University. He did his training in advanced MIS, then went to Loma Linda, where he runs both their fellowship in minimally invasive surgery as well as the division of minimally invasive surgery. Marcos is going to talk to us about peristomal hernias and robotic techniques.
There we go. Okay, so well, good afternoon, everybody. Good night for the ones in the East Coast and everywhere else in the world. I'm really happy to be able to share a little bit of what we do at Loma Linda with peristomal hernias. I started kind of tackling this type of hernias a long time ago, and as you well know, these are a huge challenge for most of the surgeons that are trying to do different things, trying to tackle them in different ways. And I think so far, and we'll review some of that, we don't really have a lot of evidence, unfortunately, about peristomal hernias. There are a few little things that can be said that are set in stone, so most of the stuff we're trying to still figure it out. So I always start this talk showing this quote from Mike Rosen in 2014. He said that, you know, peristomal hernias is one of the most difficult challenges that robotic reconstructive surgeons can have. And I totally agree with that, and I'm sure you are also on the same boat when you try to do these type of hernias. Some of them are fairly simple. If you look at the classification from the European Hernia Society of peristomal hernias, you'll see that you have some of them that are really simple. You know, like the type 1s, they are like less than 5 centimeters in diameter. They don't have any other hernias associated. And for hernias like this one, including the ones that the type 2s that also could have a small little hernia associated in the midline, the majority of surgeons will not have a lot of trouble fixing these hernias in an open fashion, not only through a midline, also in the peristomal approach, or also in a laparoscopic fashion using any of the techniques that we have available, and just putting some piece of mesh there in a keyhole fashion or in a sugar baker fashion, tack the mesh or suture the mesh, your choice. And after that, I would say 70% of the patients with type 1s, type 2s can be handled that way. The problem is the other 30% of patients. There are bigger hernias, they're more than 5 centimeters, and they can have an incisional hernia associated with it. And I really think that when we talk about robotic hernia repair and peristomal hernia repairs, I think these are the patients that we're really going to take advantage of this approach, because I think the robot will give us the tools to be able to tackle these more complex situations. So here's an example of a type 1, small defect, less than 5 centimeters. You can see right there, probably a little bit of diastasis recti or a little bit of a residual weakness at the midline there in the picture, but nothing major. Small hernia can be done fairly easy with any of the approaches that we mentioned before. I would say again about 60–70% of the patients qualify for a type 1 hernia. But these are the hernias that we're really scared about. Hernias that are type 4 with more than 5 centimeters hernia defect at the peristomal site, and also a more than 5 centimeters or sometimes 10 or more centimeter defect at the midline incisional hernia. So these are the hernias that I think we need to try to try to come up with new techniques and try to come up with different ways of fixing them. And the first question that I want to address is, should we prevent this? because, you know, when we see these patients and we see how bad the lifestyle can turn into once they're having all this pain and all these difficulties fitting the bags and all of that, the first thought is, should we prevent these hernias? Is there a role for prophylaxis? And definitely there's a lot of conversation about this topic, about prophylaxis, mesh prophylaxis in parastoma hernias, meaning putting a mesh at the time in which the in which the stoma is created. And there's been a lot of literature out there about that. I'm reviewing here a few of them. 2009, you have here a 5-year follow-up with a herniation rate of 13% in the mesh group compared to 81% in the conventional group, meaning really there was a lot of advantages of putting mesh at that time, at the time of creation of the stoma. Other papers like this one in 2010, American College of Surgeons, that shows that the herniation rate in the prophylactic group was 12% compared to 54% in the conventional group. So here we have actually a pretty nice advantage. And then the last paper that I want to quote here is the actual guidelines from the European Hernia Society for the prevention and treatment of parastoma hernias. And you will see how it is recommended by the European Hernia Society to use mesh as a way to prevent the formation of parastoma hernias in the future. So, of course, these concepts have been challenged, and I'm going to quote a couple of papers here. One in 2014, a prospective randomized control study that compared submuscular sublay reinforcement of the stoma with the stratus at the time of stoma construction, 120 patients that required surgery for cancer or inflammatory bowel disease. And you can see here that at 24 months of follow-up, 10% of the patients, of the 49 patients, and 7 of the 53 control patients that developed a hernia. So the conclusion of this paper is that the incidence of parastoma hernia was not significantly different between the control and the treatment group. After that, other papers, for example, this one is still not published, it's e-published from February 2020, that actually shows an advantage of putting mesh in patients at the time of creation of the stoma. And in this case, they didn't see a drop in the incidence of mesh, but they did see a drop in the need for surgery on those patients that actually developed a parastoma hernia. So I think the debate is out there, and we don't know exactly, even though the European Hernia Society has recommended that we put mesh at the time of the creation of any stoma. I think there's still papers coming out that are challenging that concept, and we don't have a full set in stone type of approach from the surgical community at this point for all of us. So I will leave that topic there, and I will go into more of technical details about how to operate on these patients, how to repair these parastoma hernias. And I like this paper from the Danish hernia database. It's a little bit old, from 2013, but it's nice that talks about recurrence with the different approaches. So in this particular paper, what they did is they separated a group of 174 patients into 3 groups. One group to have an open type of approach, the second one to have a laparoscopic keyhole, and the third one to have a laparoscopic Sugar-Baker approach. The median size of the defect was about 5 centimeters on all of them. And it says that after open and laparoscopic repairs, the risk of recurrence at 3 years was 17 versus 3.8% open compared to laparoscopic. And in the laparoscopic repairs, there was no significant difference in this particular paper between the keyhole and the Sugar-Baker technique. But you can see clearly there, 5.9% versus 0. Even though it wasn't significant, there was definitely a trend that was later confirmed in other papers favoring Sugar-Baker as one of the approaches to prevent recurrences of these parastoma hernias. The risk of reoperation for recurrence increased with the size of the hernia defect, and that was significant, and also with the presence of an emergent repair. So, and this is something important that I want to point out, I want you to remember. The bigger your problem, it's kind of obvious, but the bigger your problem is, the bigger your hernia defect is, the more chances you're going to have of having a recurrence. And I think this is important when you consider in the middle of your repair, if you are going to narrow your defect in the abdominal wall. A lot of these techniques are described without putting any type of stitches to close the primary defect before you attempt the mesh repair, whatever kind you're going to attempt. And I think it is an important aspect to try to narrow the size back to the original size of that muscular defect before you carry on with your attempted repair. I think that will definitely decrease the chances of recurrence in the future. And then this other paper, laparoscopic versus open, 2,000 cases, laparoscopic associated with obviously improved outcomes. Laparoscopy used in relatively healthy patients. In this particular paper, they pay attention to that there was kind of a selection bias on the surgeons and saying that the best outcomes that they saw on laparoscopy probably was because laparoscopy was used as an approach in healthier patients. Other issues with parastoma hernia repairs, do we do a transrectal approach or a pararectal approach? It's important to point out, and this has been confirmed on earlier papers and later on also, that there's no difference when you create your stoma if you do it transrectally or you do it pararectally. The incidence of hernia is the same in both. So there's really not a lot of, at least proven quite yet, that there's a difference between these two approaches. Do we have to relocate the stoma every time we repair a parastoma hernia? Well, there are papers in favor of that and papers against that. The papers that are against stoma relocation are talking clearly about the risk of reherniation at both the previous and the new stoma site. And you have the references there to talk about that. And what type of mesh and where should the mesh go? There's also no clear evidence about that, and that's an important aspect for you to remember. You are allowed to use any mesh that you want in this scenario. So I'm going to recommend some. I want to show you what I use, but it's definitely something that is open to your judgment and to use the type of mesh that you prefer. Obviously, taking into account the fact that some of these operations could be more contaminated, particularly if they are emergent, if they had some sort of issue with ischemic bowel at the same time, you will lean more away from permanent prosthesis in those cases. And where the mesh should go in terms of the position of the mesh, intraperitoneal, rectus only. There's no clear evidence that yet. A lot of papers are being written as we speak. A lot of data is being collected, but we don't have anything definitive in that aspect either. So what will be the gold standard? This is what we know. What we know is that when we do a parastoma hernia repair, we need to use mesh. The mesh will be used in an open or a laparoscopic or a robotic approach with this, which is, as we analyze these papers, robotics is a different type of laparoscopic repair with different instruments and more capable instruments. The basic principles of hernia repairs apply to parastoma hernia repairs: reduction of the hernia, resection of the sac, reapproximation of the defect, and placement of the mesh. Our approach in our institution is to use the laparoscopic/robotic approach, plus the sugar baker technique on hernias that are less than 5 centimeters with no midline defect associated. That would be a type 1. For type 2s, some of the type 2s and type 3s and 4, we use an open versus robotic approach depending on what we're trying to accomplish and the type of patient we're dealing with, plus minus component separation in hernias that are more than 5 centimeters that have a midline hernia associated with it. And this is an important aspect. I think the robot, if it's going to bring you something to this particular problem, is the ability to use component separation as a tool in an easier way, and to be more liberal in the application of component separation in this big defects, again, beyond 5 centimeters. I think the robot will give you definitely an advantage and an edge, allowing you to approximate planes in a way that you wouldn't be able to do it without it. And the third case, when we have an emergent incarcerated dead bowel situation, of course, we go through the algorithm the same way you would do it in any other type of hernia that has the same situation, in which you would debride, temporarily close the defect. Eventually, you can think about stomach relocation in this type of situation, drains, and then a second stage operation with component separation and mesh reinforcement. So I'm going to show you a couple of our cases. This is a patient that had a urostoma, and the patient presented with a hernia at the stoma site and also a midline hernia. Here I'm going to show you a rib stopa, robotic rib stopa in the setting of a parastoma hernia, specifically a urostoma. So here we're doing the dissection, and we're taking down the omentum that was adhesed to the midline hernia and also to the stoma site. Here you have the reduction of the omentum. You can see the loop of small bowel going into the stoma site. Here you're going to see how we open the retrorectus space. We're dissecting there the posterior rectus sheath off of the posterior belly of the rectus muscle. This is the right side of the abdomen. And we'll try to create this pocket all circumferentially around the stoma. Obviously, you got to be careful there. You have the epigastric vessels very close to you. You try to dissect this carefully all the way around. It's a dissection that it's fairly simple to do, and it will separate the posterior rectus sheath from the loop of bowel that is going into the stoma, and also separated from the posterior belly of the muscle. This will allow you to increase the room for the mesh that you're going to put that later. This is the midline defect. Again, similar dissection. In this case, we're going from the midline and dissecting around the midline defect. This is an incisional hernia associated with a parastoma hernia that we showed before. And as you carry this dissection down all the way around the midline defect, you will see how this two defects, the parastomal defect and the midline defect, are going to eventually become part of the same operation. Here we're dissecting. This is the right rectus. You can see the whitish area there, the linea alba, and actually quite a bit of diastasis associated with that midline hernia. And you see how the posterior rectus sheath is fully dissected all the way around both hernias, to the point in which you can now advance an instrument in between the two defects. So the first thing that we do is we close that defect in the linea alba. I used here a non-absorbable suture. You can use any suture that you prefer. What I tend to do is to do interrupted sutures combined with the running suture in order to provide more safety to this closure. Here we're doing the running suture on top of the interrupted layer in order, again, to give it more security. With this step, you can see that the whole midline defect has been secured and closed. And also we're going into the parastomal defect, and we're going to narrow that defect to make it more snugged around the stoma loop of bowel. So here's the end of that running suture. With that, you're going to have both defects completely secured in the stomal, parastomal defect case. Obviously we stop the closure at the point in which it's snugged around the loop of bowel. So what we will do now is we're going to put a piece of mesh covering both defects. So we're going to advance that mesh through the free edge of the posterior rectus sheath, and we're going to advance it so it covers both defects, the ones in the midline and also the one around the parastomal hernia site. We close the keyhole. This is a keyhole type of repair. So mainly this mesh, what it's doing is reinforcing the midline closure, but it's also extending laterally around the stoma to reinforce that area too in the retrorectus space. Again, this is an option. And what we did here is we closed the peritoneum on top of the posterior, the retromuscular mesh. And at that point, we had our midline hernia completely fixed. And then at this point, we decided to also perform on top of this a sugar baker repair of the parastomal hernia. So remember, we already closed both defects. We reinforced the defects in the retrorectus fashion with an absorbable mesh. In that case, was the BioA mesh. And now we're applying a non-absorbable mesh in a sugar baker fashion to finally fully secure the parastomal site with a sugar baker technique. So we're putting 4 corner sutures for that mesh. I use, again, non-absorbable for this. You can use Vicryl for this. It wouldn't be a problem. And then after you do that, I did 2 crowns of a barb suture. In this case, a Stratafix. First crown close to the bowel, always looking behind, making sure you don't catch bowel with that closure. And then finally, a lateral or more outer type of crown with the same barb suture all the way around. All right, so this is a reef stopa, robotic reef stopa in a parastomal hernia application with a sugar baker reinforcement of the parastomal site. And the second movie I want to show you, and with this I'm going to finish. How many more minutes I have, Garth? I'm fine? Okay, good. So this one is going to be a little over 5 minutes. In this case, I'm going to show you a patient with a parastomal hernia. You'll see the CT scan here. It will show you first the midline hernia. There's a big midline hernia right there. And then you're going to have a parastomal hernia on the right side of the abdomen, right there on CT scan. So in this case, the amount of ventral hernia that we had in this particular patient was so big that we thought he needed to have a TAR in order to repair that, and then also at the same time address the parastomal hernia. So this particular movie will show you a robotic TAR in the setting of a parastomal hernia combined with a massive midline ventral hernia. So here's the dissection of the adhesions to the midline and also around the stoma. Here you have the stoma, the parastomal hernia, which in this case is probably a little smaller than the one we saw before. And you have here the massive ventral hernia with all the adhesions and the hernia sac. We start the operation by incising the free edge of the rectus abdominis and trying to free up the posterior rectus sheath. And that dissection will be carried out posteriorly to the belly of the rectus muscle and advanced laterally. This is the right side of the patient. At this level, we're going to find at some point the loop of bowel from the stoma coming through this plane. So in this particular approach, you need to be very careful. Right there is when we start to slow down the speed of the dissection so we don't injure the loop of bowel that is going through all the layers here. So here we look, we determine where the transversus abdominis is. This is just perfectly explained by Dr. Bellester before, and it also is going to be part of the talk that Dr. it's gonna be part of the topic we're gonna hear at the end. So I'm gonna leave it there. I'm not gonna continue advancing into details about this. But here you have the dissection of posterior rectus. The transversus abdominis. How do you open that plane and push the transversus abdominis away, creating the TAR? And once you have done that, all on one side, you go to the other side, and you also perform the same TAR dissection on the left side of the abdomen. So the release of the transversus abdominis, obviously always careful with the epigastric vessels and the perforating vessels. We release the transversus on the other side. That's the transversus being released. So this is going to allow us to close the posterior rectus sheath and the transversalis fascia all together at the same time at the midline. This is how that nice release allows you to close this layer. But before we do that, we're going to close the anterior rectus sheath, and we're closing the midline here in the same fashion as we saw before. You see the hernia sac on top. Sometimes we bite the hernia sac to bring it down and avoid seromas with that. This is the rectus muscles coming together at the midline very nicely. I always, like I said before, reinforce my running suture with some interrupted sutures in the middle to avoid failure of that running suture. And then we place a mesh on one side. We fixate the mesh on the one side that we're looking at. That mesh is cigarette together with the suture, and like Dr. Ballester showed us before, then you can extend that mesh once you dock the robot on the other side. This is the closure of the posterior rectus sheath. Up to this point, the operation was pretty similar compared to a regular transversus abdominal release done with a robot, so Robotar. So then, once it's been accomplished, the next step will be to extend the mesh, and this is what we do now. We cut the suture and we pull the mesh all the way across to the other side. Remember, on the other side, we're going to have the stoma, so we need to create a slit, and we're going to cut the mesh and pass it around the stoma. The loop of bowel goes to the stoma, and then we'll secure the edges of that slit so it stays around the stoma in that retrorectus space. Once we've done that, again, we're going to go intraperitoneally, and we will place another mesh intraperitoneally in a sugar baker fashion to secure the parastomal site. In this particular case, we use stacks. After a 6-hour operation, we were trying to wrap it up, and I think that's the reason why we use stacks. But you can actually suture the mesh in place. Yes, Garth.
So if you already had permanent reinforcement.
Well, I'm always hesitant. Maybe it's old school, but I'm always hesitant about using keyhole only for the repairs of these parastomal hernias. I feel that sometimes the repair can fail. I believe I've seen in my hands at least less recurrences using the sugar baker technique for parastomal hernias. So in my head, when I repair these hernias, I'm thinking about the mesh that I put in the retroperitoneal, in the retrorectus muscle plane, is the mesh that I use for the midline closure, and then for the parastomal closure, I feel that I need to do something more than just a keyhole repair. So that's the reason why I put a sugar baker in both operations. Actually, I showed the same. But it's preference. Again, there's no evidence, very clear evidence about any of those things. There are proponents of sugar baker. You have a lot of papers showing superiority of sugar baker, but there are papers that came out in the last year or so that actually go back to trying to convince us to use keyhole approaches. So it's still out there. There's a lot of surgeons are using keyhole repairs, and I think it's valid. It's still a valid operation. I'm a little hesitant about that myself. Just trusting the keyhole approach only for these big parastomals.
All right. So thanks everyone. I can't see any of the comments, so maybe we could mic up anyone, one of the other Conrad or someone else. Conrad did an exquisite tour de force presentation of ways to manipulate the abdominal wall. I'm going to talk a little bit about component separation as well and the transversus abdominis release. I think that this talk may maybe quite a bit of overlap, but I think presented in a different way so that you can understand kind of in a step-by-step version of how to do both the top-down and bottom-up component separation. We've seen, as Conrad showed earlier, that robotic hernias have really exploded in the literature. And so while it was in the beginning just a few people doing hernias, it wasn't really well studied, it's now quite well studied. We're getting more and more data. When it comes down to robotic component separation, really the money is in the length of stay. And that's, you know, one of the reasons of why would you take a little bit longer to do these repairs? You know, open TARs got to be something that a lot of hernia surgeons were doing, and we're doing them in pretty good fashion, pretty quick fashion to get through them. But the length of stay is seems to be dramatically better with robots. So the extra time invested in the operating room really pays off with hospital length of stay. Here in this study, you can say it's 1 day versus 6 days. More papers saying the same thing, 6 days versus 3 days. And really, as Conrad said before, you got to be pretty familiar with the anatomy so you don't end up displacing someone's lateral abdominal wall in a fashion that you didn't intend. So in our practice, it's all about algorithms. Run a hernia center, have quite a few surgeons. We try to progress around algorithms, and as we progress through, you've got many different repair techniques, and we've talked about laparoscopic repairs, which are fine, IPOMs, properitoneal approaches, and then myofascial advancement. And so I'm going to talk a little bit about the myofascial advancement, and hopefully do it a little bit differently than both Marcos and Conrad have done. This, I want to throw a little pitch out there for Yuri Nowitzki's first paper on transversus abdominis release. This is really just a wonderful paper for the training resident to take a look at. It's really ripe with anatomy and gives you a lot of tips on how to do it. Sounds like Conrad's got another paper coming out on how to do this as well. But this really lays it out step by step on how to do a transversus abdominis release, whether you're going to do it robotic or open. Really, this is just a wonderful paper. What I've done is put together a robotic component separation. I know there were some questions earlier about how do you put your ports in, how do you dock the robot. I'm going to go through from start to finish some of the tricks on how to get this operation done. And so first, room preparation and docking. An XI is different than an SI, only in so much as that you're going to have to wheel the cart around to do the opposite side. I'll show a little bit of video here. Here's the XI system coming in. We'll do a standard side dock. But of course, with the XI, you can rotate the boom around. Here you can see where the ports go in this operation. So I don't use long trocars. I don't do anything funky with the arms. I usually get optical entry up in the subcostal region, and then dock my 3 ports, as you can see there. And then we're going to mirror those ports later on. And then it comes down to abdominal exploration. Here you see midline ventral defect. Here in sunny Southern California, we have lots of sun and no adhesions, so that's really nice. We don't have to worry about taking those down. But the first step would be, of course, get all your adhesions down. And then there's a couple different ways to go about it, and Conrad kind of said it, and I'm going to slow down and show a little bit of it. You can either do the transversus abdominis release from the top down or the bottom up. Conrad really showed very nice video of getting into that preperitoneal plane, finding the posterior rectus sheath and the arcuate line, and then going up. I'll show that in the second half of the video. Here's just if you were to start up top. And so for simplicity's sake and to keep us on time, this is going to show the component separation with the posterior rectus sheath already have been taken down. Okay, so here you can see this is looking at the patient's right side. We're completing that Reeves Stopa posterior rectus sheath dissection. We're going to take that all the way out laterally until we start to see some of those perforating vessels into the rectus abdominis. Here you can see those vessels that course between the transversus abdominis and the internal oblique muscle coming through and then intervening and supplying blood to the rectus abdominis. Those are going to serve as your lateral landmark of your release. Here you can see we start cutting through the posterior rectus sheath to get access to the transversus abdominis. Now, when Netter drew the transversus abdominis, he showed it coming together with the internal oblique and external oblique at the same level all the way up the abdominal wall. Whereas in fact, the transversus abdominis is almost a midline structure in the upper third of the abdomen. You'll see that in Yuri Nowitzki's paper, and you'll see it in your patients. I mean, we can dissect through that transversus abdominis. And you can either use a hook or scissors. We like to use scissors at UCSD, and then slowly progress through trying to preserve the underlying transversalis fascia. And here you can see as we move, we've gone through the bulk of the muscle and then down and entered the preperitoneal plane down low. And so that's the transversus abdominis release from the top down on the right side of the patient. Next, mesh sizing, port placement, and redocking. So this will be an effort to obtain the correct mesh size and get your other ports in. And here you can see the posterior components are down. And then what I like to do for mesh sizing is to measure about half of that, to measure the length of the posterior component. Right now, the abdomen is spherical, but when the insufflation is let free, we're going to be more in that flat plane. So if you measure top down of your posterior component, you'll be able to size your mesh pretty accurately. And here we're going to tuck the mesh in underneath the ports on the contralateral side. And you can see that those ports were just mirrors of the prior placed ports. And now we're going to do a similar technique that Conrad showed earlier with the bottom-up transversus abdominis release. So we're going to complete the preperitoneal dissection down in the pelvis. Pelvis is down here. And you can see your rectus abdominis there, epigastric vessel. And then as we dissect, you're going to come across your prior placed trocars, right? You can see this hole here was in the peritoneum that was down here is from that trocar. And then it's all about doing that trick that Conrad taught me and has taught so many others about creating that cave underneath the peritoneum. And then right now we're coming through the transverse fascia. And then as we go up higher, that dissection is going to become more muscular and become the actual transversus abdominis release. There you can see the other trocar was replaced back on the anterior side of the flap. Here you can see the holes in the peritoneum from that peritoneum from that prior placed trocar. All of those holes need to be closed. Here you can see I closed several of the holes with just one running absorbable V-lock suture. And then we're going to go forward with anterior fascial reapproximation. I can't remember if Conrad said that he does his posterior stuff first or second. I like to do my anterior bites first. I think that offloads some of the tension on the posterior closure if you've got it. You can also see here that we have less space than we did before, and that's because we've decreased the intra-abdominal pressure. And I like to really take that down as low as still possible to have working space. That just offloads a little bit of the tension in the closure. Here you can see we're grabbing some of the sac and then grabbing linea alba. These are some of the tricks that you can use to get that together. And then really it's about sequential tightening of the suture. Once we get the entire anterior fascia closed, make sure you remove your needles, right? And then it's posterior components closure. I like to do bites in the fashion that Conrad was talking about a little bit earlier. Your angle is certainly a little bit better if you do it this way than if you try to sew it in a baseball fashion. And then really just get those components closed up. I was kind of hanging the components off the roof to give you a little bit easier, quicker suture pattern. I didn't trust the V-lock on that one, so we tied a knot. And then deployment of mesh and drain placement. Again, you can see this is the trick I learned from Conrad. You can see it on a lot of his videos about that. That stitch was strategically placed prior to the operation, and then we go ahead and roll the mesh out and put the drain in. This is a hybrid mesh that has an absorbable and a permanent component to it. So really, in conclusion for all of this, and hopefully we have enough time to ask the audience some questions, robotic hernia repair is here to stay, whether it's for inguinal hernias, IPOM hernias, preperitoneal repairs, component separation. I think there's so much you can do with the robot that fits the abdominal wall. There's really an active research community interested in determining the value of this and the outcomes. Certainly something like robotic component separation, having the length of stay takes care of cost considerations in a quick fashion. Robotic transverse abdominis release affords replication, a replication of well-established open techniques. But not every nail needs this hammer. If you look around the internet, there's some pretty small defects being put together with transverse abdominis release that would probably be better served with some of the techniques that the other surgeons in the group had showed earlier. So thanks, and we're gonna open this up now to any questions you have. I'll see if there's anything that came through if I can.
Hey Garth, Hisham Atwal is talking about what's the learning curve for TAR?
You really got to be able to do it open before you do it robotic. Now that may not be the case. I mean, with the current generation, I've had a couple of fellows come through now, and they're better with the robot than they are with the laparoscope. You know, which is kind of disturbing, but I've seen it. But one of the things that you talked about earlier is you really got to be good with the anatomy. And if you release the internal oblique, or you get all the way through full thickness down the wall, you're going to cause that patient a real problem. So I think the key is being comfortable with the anatomy, and once you're comfortable with the anatomy, I think you can do these techniques. I mean, the video that I just shows that, I mean, it's not technically complex. It's just knowing the anatomy and taking your time doing it. So I think to be able to do it, it depends. So when you say what's the learning curve, do you want to do it really fast, or do you just want to get through it, or do you want to do it safely? And I think by probably 10 or so, you're getting faster. But I think the key to the safety is in knowing your anatomy. What do you think, Conrad?
No, I totally agree. You know, I've always been.
No, I totally agree. You know, I've always been resistant to teach somebody a robotic tar if they don't have a good experience in open tar, because I get worried in the event they get stuck for whatever reason robotically, they open up and then they're completely lost, because it really offers a different perspective. I think anyone who knows this anatomy well, who respects it, can do a case like this. So I have my third-year residents doing these big robotic tars, but we hammer in anatomy, and I'm watching them like a hawk, and they're able to complete these with very little previous experience.
I find it a little bit more, it depends on how much experience they have with a robot, but sometimes they can see the planes a lot better with a robot than they can see it open. So that's an advantage. I find it easier sometimes to explain where the beginning of the transversus abdominis is and all of that when you are with a robot. It's such a beautiful thing to be able to change the angle of the camera on the fly, you know, everything high definition, everything magnified. To see the tar plane as an assistant in an open operation, it's kind of hard. You need to lean forward, you need to look down there, it's dark, you can't really see much. So I think the robot gives you an advantage to teach these things also.
One of the things that I think about, and if cost was nothing,
No doubt.
or so if cost was no object, I think there would be a nice training cascade that you could do. And I think that it would probably start with a pre-peritoneal repair of bigger umbilical hernia, right? There's not really any critical structures to hurt. You're practicing it in your pre-peritoneal plane. You're practicing suturing. You put a piece of mesh in. And then maybe move to controls, and then maybe move to the more complex stuff. Now, I don't know if you can buy a robot for hernia, but for training, that would be a great step down. What do you think about inguinal hernias as the gateway, Jocelyn? I
think that the inguinal hernia is a perfect one, and I think they accomplish more than just the using the robot. All that comes along with that, I think they get very comfortable. They're quick cases. They can accomplish different steps easily, and it's anatomy that they need to know anyway. I think it's about time they could just do it all at once and be done with it. I think they feel comfortable, and then they can branch on to the abdominal wall from there. I think the anatomy is a bit more exciting, even though there's things they can hurt. There's things that they should be able to also fix if you're graduating the resident through properly. So I think it's actually a good starting spot.
Yeah, and so
I was super anal.
I agree. It's kind of funny that I was super anal about letting residents do inguinal hernias because of all the things that you were saying, Jocelyn, that you can hurt. And one thing that I hate, if I see a little bit of blood in that preperitoneal space, that kind of ruins my day. So I would actually let the residents do more complex ventral stuff than inguinal stuff. Since going to Creighton, I'm getting them in early with inguinal hernia, and you know, just the ability to dissect peritoneum off the wall and being able to understand those different layers, the pre-peritoneal, the pre-transversalis layer, is a very nice stepping stone to get into more complex.
So there's a
ventral
question
stuff. So,
right now
yeah, I
about
agree with you guys.
prophylaxis. I treat my big abdominal wall reconstructions like major abdominal cases they get DVT prophylaxis.
Absolutely.
I use Robotic, maybe that's bariatric surgery. How about you guys?
Yeah, I give them heparin as
Good.
well.
So, Marcos, what is the training cascade at Loma Linda for, I know you guys are very heavy into robots for your residents. How do you organize that training cascade?
Well, the beauty is that in our service, in the MIS service, we have residents that are at different levels of training. So we have a combination of, they're not all the same year. So we have them in different stages. So it's nice for them to be able to come as a PGY1, and they're sitting there, they're looking at the robot, they're assisting with the nurse, they're putting instruments in and out. They kind of get an idea of what is the robot, how it moves, kind of the instrumentation part of it. Then we get third-year residents that come and they do all the basic stuff, all the gallbladders and inguinal hernias. I totally agree with inguinal hernia. To me, is the most prolific type of procedure to be able to teach somebody robot moves. It combines suturing, it combines delicate movements, it combines rough movements also. When you pull from that sack, you pull hard. And all of those things, you're doing them under visual cues only. You're not using any type of haptics, right? So it is a great bench procedure for learning robotics. So I think the bulk of the PGY3 residents, they get the exposure to that. And then we have them again as PGY5. So that's when they do the more they get the exposure to the foregut robotics and also all the complex ventral hernias. You know, so I think if you have the ability to kind of stage your residents that way and kind of stage the experience they have with the robot that way is an advantage. Not everybody could do it that way, maybe. But then also what you do in the lab is an important thing. If you can have your patients go through a lab in which they can break all they want and learn without having the guilt of doing it on the patient, I think it's is the best thing. But I mean, I'm talking about a lot of resources. I understand some people might be listening to us from other countries in which all these resources are not there. So it's difficult to do it in those situations. But I guess the spirit is to try to go as sequential as possible and get them hands-on as early as possible.
I totally echo Marcos's talk on the lab.
I totally echo Marcos's talk on the lab, whether it's a resident versus an attending. That's why you see me at your Center for Future Surgery all the time, Garth. Not to mention the fact I love La Jolla. You guys, I'm super jealous. I love surfing in that area. But a lab is, I think, is super helpful in getting surgeons to the next level, being able to understand the different anatomy as well as the robotic moves that you can employ during the execution of the case.
SAGES and the courses that they put on. We've really been ratcheting up robotic courses over the last couple of years, and you'll see many of these faculty members there, and also lots of other people. So the residents should look out for that. You can go to SAGES, the website, you can see the different offerings that we have, and also ask your program directors. Each of your program directors get information about the SAGES courses, and we'd love to see you at one of these courses and do some hands-on stuff. So with that, it's 6:02. I would love to say thank you to all the faculty and for everyone that came and listened to us talk again. Thanks. And so we hope to see you at SAGES in hopefully August in Cleveland, Ohio. Cleveland rocks. We're having a meeting as of now. We would love to see everybody there.